So this session is about advanced practice and career development, and we have three speakers this morning. The first speaker is Miss Karen Fader, who's from Canada, and she's very kindly agreed to present on advanced practice and the international perspective. Thank you, Karen.
Thank you very much for the invitation. What happened was, at the SNMMI meeting last year, Liz and Jeff and I and our CEO, Francois, had a meeting, and they said, it would be really great if you could come and present. CMRT, the organization that I represent, they encompass 4 different areas of practice, so the nuclear medicine, radiological technology, MR, and radiation therapy. And for there to be a nuclear medicine president, I think it's only happened like 5 times in 75 years. So it was a great opportunity to come here to the World Federation and present. So thank you both very much for that. So I said, let me know what it is you'd like me to speak to. And they came up with the idea of advanced practice. And can you talk about what it looks like in Canada, the US, the UK, Australia? And to be honest, I am not an expert in advanced practice in those countries. But what I did do is take it from an international perspective and attempted to distill information from the different models of advanced practice in those countries to come up with this presentation. So in the end, I sort of changed the title and said, is there an advanced practice international perspective? So to start, I have nothing to disclose. And I would like to speak to the difference between enhanced practice and advanced practice, because there's often some confusion around that. Enhanced practice is those activities or skills that extend beyond your initial education, or those expectations, those principal expectations, or your scope of practice. And we often, many of us do extended or enhanced practice in what we do on a daily basis. But looking at advanced practice from these different countries and these different organizations, at the CMRT, we recently have developed an advanced practice model. And in it, we define it as a higher level of practice where clinical responsibilities are routinely exceed the current principal expectations. It also requires analytical skills. You need to synthesize that evidence-based knowledge and work autonomously to optimize patient outcomes. So in Canada, what we have for advanced practice currently is in the radiation therapy area of practice. And we have radiation therapists that are doing advanced practice, very niche type advanced practice in various core centers where cancer care is a center of excellence, like the Princess Margaret in Toronto. If we look at what the UK, or how the UK looks at advanced practice, they talk about that advanced practitioner who demonstrates expert clinical practice to secure service delivery. They have to engage in that expert clinical practice, and when they deliver it, it has to be of high quality, and it has to be patient-focused care within their realm of whether it's diagnostic imaging or radiation therapy. Now, in the UK, it tends to be the reporting radiographer. So someone who specializes, their clinical expertise is in chest x-rays or in MSK. And as an advanced practitioner, they would do reporting, but they may also, the next level up, be a consultant. But that tends to be what advanced practice is predominantly in the UK. In Australia, I went to the ASMIRT for my information, and how they describe or define advanced practice is when a practitioner regularly performs beyond the core practice boundaries. So, and they're using the tools, the resources, and the imaging that they have available. It's professional mentorship is another component of it. So you can see that there's some thread of similarity as I look at how these organizations define or consider what advanced practice is. Now, this particular, in the United States, the SNMMITS section has an advanced practitioner. They define it as a nuclear medicine advanced associate, or an NMAA. The important piece here, and this is something that I will speak to again, is that it needs to fill a special gap. So it needs to meet a need. It's not created for the sake of creating it, but because it's going to provide a service or a care that will make delivery more seamless. Now, I don't see David Gilmore, but he told me that essentially in the United States, the NMAA is no longer functioning, that they're closing the schools, and they really didn't get the uptake that they anticipated. So if we look at frameworks, you pull out the core, I call them pillars, of what advanced practice is for these different organizations, these different countries. If we look at the CMRT, we talk about improving patient outcomes, critical thinking, complex decision-making, autonomy of role, leadership, research. There is a strong emphasis on the autonomy piece within our framework. It's very clear that the individual who's functioning at that level has to be doing something that is independent, and you're not directly necessarily supervised by someone else. If you look at the UK, they talk about being an expert in the practice, professional leadership or a consultant, education, training, and development, practice and service development, research, and evaluation. Now, for this organization, I can tell you in being attending the European Congress of Radiology for the last 2 years, they are very, very strong on research. So it's very key and it's very critical to what it is that they do in advanced practice. Looking at ASMIRT, they talk about collaboration, communication, professionalism, evidence-based judgment, clinical expertise, scholarship and teaching, and clinical leadership. So again, you're seeing the terms that are being used to describe an advanced practitioner. There is some consistency regardless of which framework that you look at. In this particular framework, leadership is one that really stands out. And then we have the American version from the SNMMI, and looking at the framework there. Practice-based decision-making, consultancy, leadership, professionalism, communication. Again, very similar pillars of an advanced practitioner. In this case, I wanted to pull out decision-making. If you look, it's alternatives, it's uncertainty, you're working autonomously, you're demonstrating leadership, but really this decision-making piece, the part where you are deciding how patient management is going to change, what decision that you're going to make and the impact that it's going to have on that patient and their outcome. And something I'd like to draw your attention to is, as the responsibility increases, so does the risk. So if we look at the high-risk consequences of an advanced practitioner, that is where you start to see the difference in practice. So we know in general practice, we're all professional. We all have clinical expertise. We all are making some decisions on a regular basis, but what I'm talking about is at a higher level in that it's the risk in making those decisions. So when it comes to education, regardless of the framework that you look at, Master's level education is what is required pretty much across the board. Now, whether it's formal master's education or it's a master's equivalency, it's different depending on the framework, but that is the level of expectation in terms of education. And of course, once you have that advanced practice certification, just like when you are in our regular practice, we are expected to do continuing professional development. So is the advanced practitioner. And depending on where you are, for example, in the UK, very, very rigorous CPD and assessment of their skills on a regular basis, and they need to meet a certain level or they lose their certification. So when I talk about an advanced practitioner from a concept level, it's not a moment in time. It's a state of being, and it's not a credential. It's not a credential. I mean, you will argue with me, yes, Karen, it is a credential. You get certified, you're an advanced practitioner. But my point is that it's more of a transformed practice. So you have taken a journey. Someone would say, I have 20 years experience, so there's my expertise. I've been a manager, so there's autonomy and decision making. All the elements that if you look at them in isolation and you just ticked boxes, you know, I have my master's, you would say, then why aren't I an advanced practitioner? Because it's more than that. It's a transformation of your practice that takes you to an entirely different level. And I think that's the point that sometimes we miss. We say, let's just make an advanced practice certificate and people do this, and then they have that credential. It has to be more than that. Benefits to advanced practice. So we have improved systems outcomes. Now, the literature demonstrates that, in fact, when you look at an advanced practitioner and the impact to the system, it's the healthcare system broadly, there are benefits. There are changes in wait times. There is improved patient compliance. There is improved patient satisfaction because in an advanced practice situation, they tend to get more one-on-one education, and it feels more specialized and more personalized. And it takes the time that someone else would be doing something, it fills that gap or it fills that need. And so to the system, there is evidence to support that there is a benefit. Now, the question is, are there improved patient outcomes? Currently, there really isn't the evidence to support that. Even in the UK, where advanced practice has been around for a long time, it's very well established, they've worked out the kinks in a lot of ways, they will admit themselves that something that they haven't really done is the research to prove a direct benefit in terms of improved patient outcome. So I had the opportunity at ECR this year to speak to Marianne Hardy. She, I guess I would call her the guru of advanced practice in the UK. Her and her group, they did a study looking at the impact of advanced practice in the UK, a systematic review, and they were able to demonstrate, yes, as advanced practitioners, we have the same level of accuracy as the other health professionals in doing what we do, which is chest and MSK. So we're very, very good at it. And we've proven that we can do it, and we are very good at it. And we know that there's an indirect benefit to the system. But there really wasn't the research there to absolutely say that there's improved patient outcomes. And so they recognize as a group they're in the best position of anyone who has advanced practice currently to start doing the research to prove that. So that is what they will endeavor to do in the coming years. Very interesting conversation with Marianne. So, what are some of the barriers to advanced practice? Well, there's probably a long list, but I only picked a few. One is role clarification. We struggle with it, even just as I just went through, but I did demonstrate that at the core, we all have a common language that we use to describe advanced practice. So it is there. I think we can have role clarification. It's just so far, it tends to be a little bit of floundering and as I said, confusion between enhanced and advanced. So we as professionals need to be clear about what we are, who we are, how do we define ourselves as advanced practitioners, and be very clear and concise about that. Our purpose. So the role has to be, as I said, meet a need. You can't just say, we should have advanced practitioners in our institution and think that you're going to get buy-in, that people are going to say, yeah, sure, I'll go get my master's and I'll take on this extra responsibility and I look differently than my colleague. How? So it really has to be about where you are and your practice and what it is that you can bring to the healthcare team as a team member to fill that gap that needs to be filled. Lack of support. So this is, it's a challenge for sure to have other health professionals look at us and say, yes, we want advanced practitioners. There's always going to be a little bit of juggling in terms of scopes of practice and what's typically what I do versus what it is that you do. And if we don't have support of those other health practitioners on the team, we're not going to move this forward. If you don't have buy-in from those other groups, you're going to get a lot of resistance. And if you're constantly fighting a battle with different groups and trying to say, but you need me, I'm trying to convince you that you need me, you're not going to be as successful as if you had had the initial conversation and they're on board from the beginning. So for example, in Canada with the radiation therapists, the radiation oncologists really wanted the radiation therapists to take on this role. They supported them. They were part of the working group that helped define what it looked like. Cancer Care Ontario put money into it. So it was very collaborative, and everyone was on board and knew what it was they wanted from the beginning. So less resistance. This is a position statement that came out recently from Rancer, where image interpretation by radiographers not the right solution. Interestingly, it was originally written in 2010 but didn't come out until recently, and within the evidence that they use in that position paper, a lot of it was old, but one of the pieces of evidence that they did use was in fact Marianne Hardy's systematic review that spoke about not having direct improved patient outcomes. And so they drew a hard line and said, unless you system benefit, it's irrelevant. Shortages of radiologists, it's irrelevant. The only thing that really matters if you want to be an advanced practitioner is you have to demonstrate a direct improved patient outcome. And of course, she had just done a systematic review that said that hard evidence really isn't there. So that's why they took the hard line. Since then, there has been communication back and forth and a position and another document issued by the ASMIRT. So, strategies to advance practice. They are actually simple in terms, but not easy to do. So, the first thing you need to do is you need to understand your landscape. If you don't know what's happening out there, if you don't know what the demand is or what it is people are looking for, if you don't understand your landscape, you don't have a foundation. Communication, you need to start talking about what is advanced practice, why do we need it, do we need it? You need to collaborate. You can't do it in isolation. You have to go to your natural clinical partners and make it a team effort. Educate. You need to separate, you need to start to talk the talk so people understand what advanced practice is in regular conversation and not just at certain events like this. And then vision. So once you know what you want for your advanced practice, you need to hang on to that, you need to see what that is, and you need to keep going forward, having that as your beacon. Now, somebody would argue, Karen, shouldn't you have a vision first? Well, I think actually what you have first is an idea. After you work through the steps, you have your vision, and then that is what you focus on as you try to bring this to fruition. So, the future of advanced practice. Not really sure. It looks different in different countries. It's at different degrees. Obviously, the UK has been around for a long time. In Canada, it's only been a few years. UK, it's radiographers. In Canada, it's radiation therapists. But the key are the points that I have already discussed, and that's the commonality, and that's the model that if you keep that sort of common core model, you should be able to use that just about anywhere. We as professionals have to take responsibility. If we feel that it's something we should do, then we need to do it. If it's something that we feel that we don't need to do, then that's okay too. But make sure that that is what you want, but if that's your decision, then that's fine. Leadership. So what is how can we support our leadership and what it is that they're trying to do for us as professionals and moving us forward, and whether or not there is a role for advanced practice? And then research. It always comes down to research. If we are going to demonstrate that advanced practice is something that we need to have, that we need to be a part of, then we really need the evidence to prove that there is that it makes a difference. So once we embark on an advanced practice role, it will be our responsibility to make sure that we do the research to prove that there are benefits to patient outcomes as well as system benefits. And I have to put a plug in here at the end. Jeff, the journal. So when you're doing this research, it's really important to publish. It's not, we can't just do things within our departments and say, oh yeah, we showed that there was a benefit. We really need to make it a research project so that we can publish, have it out there in those peer-reviewed journals so that others can take that and use it to support their endeavors in advanced practice. So my reference and questions, I believe we're going to leave to the end. So if I've said something that has piqued your interest or not, something that you say, Karen, I think you're crazy, please hold on to that thought and ask me when we come to the panel. Thank you.
Thanks, Karen, for a very interesting overview of what's happening out there in the world of nuclear medicine in advanced practice. So our next speaker is Pete Tues. He's going to talk to us on advanced practice in nuclear medicine, a practical necessity or unnecessary or... Well, come on, Pete, that's a very complicated title.
Sorry about that.
Especially after the gala dinner.
Well, you can go to the gala dinner.
Oh, well, there you go.
I was a good boy.
Pete.
All right.
Thanks,
Good morning,
Pete.
everybody. As I said, my name's Pete Tues. I run several nuclear medicine sites in rural Western Australia. I'm going to give you my opinion on rural or advanced practice, which I've been performing, I think, for about 20 years, unbeknownst to me at the time, in a rural context, where the needs are most significant. My disclosure is if my vision for advanced practice comes true, my business will make money. But I am a B Corp, which means that all my money has to be reinvested back into my local community, so I can't go off and buy a Ferrari. So hopefully you'll look nice upon me in that regard. I love the sound of my own voice, Liz and Daphne, as you know, and I'm going commando at the moment. I haven't got speaker's notes, so just kick me along. This conference... All these conferences filled me with enthusiasm, motivation. I was just talking to a technologist that I studied with 25 years ago on Friday, and we both looked at each other, Dom, and said, this is a fantastic profession. We're really at the cutting edge. We talk about precision medicine, targeted therapies. I just listened to Sam Gambier's talk this morning at Stanford, and I think, it just blows me away. And we talk about the radiopeptides. I just listened to alpha V beta integrin PET CT scanning for pancreatic cancer. And I'm thinking, this is magnificent. We've got the PET MR, but the conference for me is very bittersweet because I'm going to leave here, fly back to the bush, and I know that 10% of the Australian population is not going to get these therapies. I should have also said I'd like to acknowledge the traditional owners of Melbourne, which is under the Kulin Nation, who occupied these lands before European settlement. I'm sorry, I should have mentioned that at the beginning. So, this was mentioned by an Australian politician who 99.9% of everything she said was rubbish. She lasted not long as an Australian senator, but she said this last year, and these words are always in the back of my mind when I go 6 hours out into the bush and run what I think is the most remote practice on the planet in a place called Kalgoorlie. It was Senator Lambie who did this welfare speech, and most Australians will know who she is because she was very topical, but it's true. And that gap is getting wider and wider, and this conference just underscores that to me. Last year, some data was published for 11 countries in the OECD. It was published in the UN. And Australians, rightly, I'll stop this up, rightly pat ourselves on the back. We're second in terms of overall performance for the least cost compared to the US, which was the last at 11th. For the most expensive cost. That's the outcome of managed care and corporatisation of health. That's my little political statement. So, but whilst we're patting ourselves on the back for coming second, we're seventh in equity. And I reckon those numbers are soft. When you unpack those numbers, and I did, when you look at the more regional remotes, you look at about 600,000 to 800,000 Australians, we're probably well down on the 25th scale, in my opinion. Anyhow, I've got to check that data. Where I work, this was a few years ago now, but each month, at least twice a year, the local newspaper's saying we're crying out for doctors. We have a high degree of overseas trained clinicians. Only 27 doctors at the moment for a very large population. It's got the lowest doctor per population ratio. And just last month at a Senate hearing, and I'm just trying to provide you the context of why I think AP and why allied health professionals can really help here. It's important. Just last month in the Senate in Canberra, their own Department of Health gave testimony which says our equipment is of poor quality, and they went on further to say, and it probably is missing diagnoses. This is on Hansard, which is a parliamentary record. But can you still let us use it for the next 3 years and not make changes to capital sensitivity because we've run out of money over in Western Australia, because Victorians steal our GST, but also it's because they just spent 16 million on a football field. We can find that much money for that, but we can't find 500 thou a brick to buy a 128. So the oldest CT scanner in Kalgoorlie, in Western Australia, is in Kalgoorlie. So for the German technologists and the internationalists, that's where we've got one of our practices, the most remote. It takes about 6 hours to get there. To drive, we fly in, fly out. It's the second largest democratic electorate in the world. Canada's got the largest now. It covers 770,000 square kilometres. It's about 250 square miles. It's big. We pump $9 billion into the Australian economy. 60,000 population, about 38 live in Cal. The rest are splattered around in very, very remote areas. And about 12% of Aboriginal descent. We've got no MR, no advanced CT. We've got a clapped out 16 slice. No PET CT, no stress echo, no resident oncologist, no resident orthopaedic surgeon, no full-time equivalent resident specialists. We've got a 6-week waiting list for ultrasound, although I support a private ultrasound service, so we try to keep that number down. And we've got 90% overseas trained doctors. When I first started 20 years ago, it was the other way around, an Australian trained doctors, but we're draining India, Nigeria, lately Burma or Myanmar, of their best and brightest. They're after a visa to come to Australia. So they go to these godforsaken places from the tropics to the desert, give it 2 years, and then they've just got their ticket and they're out of there. So I'm constantly trying to train them. And honestly, their training goes up to a CT scan at the most. Nuclear medicine, what is that? It's very hard. And we have about 1,500 people fly. When in doubt, fly it out. That's the rule out there. That's 4 people a day. Now, that's acute medicine, and it's not, I'm not saying nuclear medicine is going to fix all that, but we have a high proportion of fly-in, fly-outs. It's a very, very expensive operation. So, what do we have? Well, we have the worst mortality and the worst morbidity statistics in Australia. So, and on top of that, we have a high level of dislocation for families when the mining families, sadly might have a family member who's got cancer. They've got to go to Perth for treatment. It's enormous transport costs. We know that for every 100 kilometres away from a radiotherapy unit, death rates go up 6%. I'm 6 hours, I'm like 700 kilometres away from a radiotherapy unit. And a lot of people just forego treatment. They can't afford it. Not a good picture. In terms of prostate cancer with Aboriginals, I can't see anything from this thing. Oh, here we go. Sorry about that. This was published a couple of years ago in the British Journal of Urology. You wouldn't know. I thought lung cancer was the biggest killer of Aboriginal people. Prostate cancer is very, very common in Aboriginal men. The 5-year survival rate between my patients in Kalgoorlie and the patients in the city is 50%. 50%. It's not good enough. The Closing the Gap, which some people in Australia will know about, finishes next year. $30 billion has gone into that over 10 years, and it's got worse. The last report showed that on many indicators, things have got worse in health, particularly. And many groups look at health professionals as low-hanging fruit to try and... we're only a small cog in the big wheel, but we're a very important cog, and we can do something ever so small to fix this. Coronary artery disease is the one that makes my blood boil. For Aboriginal people at my age, they've got a heart that looks like a 65-year-old. There's no silver bullet to fix this. There's a lot of reasons for that. Diseases of consumption. The other point I try to make is this conference talks about some really esoteric cancers. The prevalence of some of the cancers we've been presented to are, very, very tragic. It's fantastic we can fix them, but they're still dealing with scurvy, infection, diseases of the Victorian era up here. And these are major numbers. So you just try to keep that in mind. Aboriginal patients have poor polypharmacy. There's poor adherence to medications, as we know. But 320 million per annum is estimated to be lost because of avoidable admissions. So what do we need? Well, we need doctors, nurses, cancer, therapy units, obviously, better equipment, and we need to try and pay for patients or sort of support patients in transport. None of these, they've been talking about this for 10 years. Not a lot have changed. I think we should empower allied health and paramedical people and tap into their knowledge base and use them more effectively in rural areas for those practitioners that want to step up. I want my technologists to know that this is a heart attack in evolution and this patient could go on arrest. So I want to know that you've done the stress test, your doctor's gone to see another patient, or you're in a solo practice, and your patient is diabetic, is an Aboriginal, not feeling chest pain because of neuropathy. This shows up while you're doing a gated SPECT. What do? You get them off the bed, you get them on oxygen, and you ring someone in a hurry because this could go to VF. I want my technologists to say, look, I've just finished the end of the day. This isn't the same patient, but it's exactly the same pattern. He was a post office officer for a small town, 3,000 people, delivers a post every day, real important. He's diabetic. You know, the only medication he is on is Quick Ease. It's not even a medication, or maybe it is, I don't know, for reflux, anti-gastric medication. We did a stress test, everything looked quite good. ECG was silent, looked crisp. But he's got a big hole and he's got an LAD problem. It could be a widowmaker. Am I going to fly back to Perth and not ring somebody? Nah, straight to the hospital, mate. Get on. He needs to be on a beta blocker. He needs to be on aspirin, and he needs a cath lab. He needs to be flown out. And we each, you know, every 2 or 3 months, you actually do something with it. Just actually change this guy's management. He may have dodged a bullet here, and it's really empowering. It's fun. I use GP anaesthetists. I use emergency doctors to help with stress tests. They've just come off a shift. They may have been helping the obs and gynae guy deliver a baby at 3 in the morning. Mate, you've got to do some stress tests at 8 o'clock. There's 5 lined up, and this ECG shows up, and we're about to do a Pasantin. Are you going to do a Pasantin on this fellow? Can the techs in this room know? You know, do you know whether you should or not? This is second-degree AV block. You give Pasantin to someone with that kind of situation, they haven't got a pacemaker in, you're going to potentially have a problem, a big problem. So that sort of stuff, more eyes looking at a problem do help solve a solution. I want them to know, particularly with this fella here, you know, this thing here is the worry for me. We all know what that is. That's prostate cancer. It's multi-metastases. Do I do anything? You know, he's no known pathology. He's come to us because he's got a sore hip. The overseas trained doctor has sent him for an X-ray. The X-ray was probably misread and unclear. They've come down for a bone scan, done the bone scan, to fly out. Am I just going to leave it at that, wait for the report tomorrow? He's got a sore hip. That could be a pathological fracture in evolution. So what will I do? I'll ring up the hospital and I'll just self-determine X-ray, just to look at the structural integrity. Ring up an orthopaedic bloke, he's going to fly up in a few weeks, and say, like, you need to get this guy into bed, and potentially they might stick a pin in it to prevent this guy having, dying from a neck or femur fracture, which is awfully painful. I want to know the tech doesn't need to go to his doctor and say, with the renal one on your right-hand side, when the regressums often came like 3 months post-stent in his kidney for drainage, and a plus or minus Lasix after DTP scan. It might be a sort of prosaic thing, but you've got to ring a clinician, send it down a telehealth line, do I stick Lasix in this patient? And if I'm going to stick Lasix in it, and Jeff, is going to run a course soon, what are the contraindications, or what are the potential pitfalls of that? And again, this is another patient, comes in with, on a Zimmer frame, farmer, tough as nails. He's come again with pain. And by the time I've looked at the request form, I've taken medical history. The reason I put this up is I want my text to ask medical history, because from the time of the referral to the time of coming to the scan, he's had a whole stack of structural imaging, but with a different doctor. But I go chasing up these results, and he's come for a bone scan, and this is a mottled appearance, and I don't have all the slides there, but the body from top to toe is full of cancer. What's the bone scan going to do? He is in real pain. This guy needs a palliative care therapist. He needs someone to help him with management. He doesn't have the bloody bone scan. I'm a businessman. I should do the bone scan, but I'm a health professional first. I'm not going to do it. So I ring up the doctor and tell him, send him home. So the previous speaker sort of touched onto these issues, and it's a busy slide, and I'm sorry about that. But there's been a lot of effort overseas in the space of advanced practice. Has been mentioned before, and in the interest of time, I won't go through it, but the UK really has been the leader in this perspective, and that's been a practical necessity. There were 1,000 chest X-rays not read, and half the people were dead. I don't know if you've read that paper. They had a major problem with reporting. So that really was the practical necessity there. Radiologists weren't around, so the radiographers stepped up. But you need to be able to work autonomously. The nursing practitioner model is very important in Australia. That was very contentious. The doctors saw it as the thin edge of the wedge, thought it was going to erode their territorial space. But the world hasn't fallen in since we've had the nurse practitioner model. And every day they prescribe antibiotics to Aboriginal patients in the middle of nowhere, or they help with pain management. Very useful. And so that's something I think we should look to. Health Workforce Australia, another one of these think tanks that gets a lot of funding for nothing, comes out and just tells what we already know, which is basically that it'd be very constructive to have more use and greater use of allied health professionals in rural areas. Thanks for that. So in the country areas, I don't have on-site physicians, registrar, pharmacist, physicist. I don't like being calling myself senior, but that's what I am. Nurses, we don't have one of those. We don't have a therapy clinic, PET CT and what have you. But we have got a hell of a lot of cost because before I start the day, I've got a flight cost and I've got an isotope cost. But that gives you a context of the environment that I'm working in. As I said, the UK have done very well. I think the USA, when I looked at the chronology, this followed on shortly thereafter. They did some very, very good things. Very good things in terms of the nuclear medicine advanced associate. I'll talk about those in a moment. We've talked about Canada and New Zealand. New Zealand are kicking goals in many respects, but where are we? So one of my techs through Jeff's college a few years ago did a survey, and she looked at 54 people. I know the mathematics is a bit rough there, but it was 54 people from a reasonably broad spectrum back in 2015. And they had 50% of them either had no doctor on site or infrequently had a doctor on site. And 74% indicated support, most favourably in the bush. They saw it as an area of getting high job satisfaction, great opportunity for professional development and gratification. And they also did look at remuneration, and I'll touch on remuneration in a moment. They would like on-site certification, so learning on the go with a little bit of formalised coursework later on. Most of them thought that the regulators would not approve, and that a little bit more than, say, 60% or 55% of the doctors would approve. So that was a concern for them, for many of them anyhow. Our practice board last year published results of 1,300 medical imaging technologists, get their viewpoints. The take-home message was here that many technologists thought that advanced practice was something extra special, but when you looked into the side of items they actually thought were advanced practice were actually minimum standards. So that was an issue, a big problem. It was quite heterogeneous. In terms of what the board thinks an advanced practitioner skill is, it's very non-specific. You just need to, it's basically self-assessment. There's nothing precluding you to calling yourself an advanced practitioner in this country right now, which is maybe a good thing, but it's nice ways to sort of certify it. I think would be better for public safety. They also looked at the respondents' attitudes to what opportunities are available, and there was they all thought there was quite a paucity of opportunities and availability, which I found very surprising, particularly those who work in teaching hospitals, which has extraordinary resources and these MDTs, and there's all these things you can do. So I was surprised at that. In Europe, they have a two-tiered system, apparently. I haven't really examined it too closely. They published in 2011, Advanced Practitioner 1 and Practitioner 2, and in the interest of time I won't go through that, but it just gives you an idea. The Kiwis are working on a model which is more postgraduate, and this is from the radiographer level, which sort of leads to a PhD. The radiographers in Australia, I'm not sure how this has been implemented, but they published in 2014, and they, as you can see there, have quite a sort of stratified model, which does look a little bit confusing for me, but it ends up towards a consultant practitioner, which those reading chest x-rays. And honestly, I will put my chest in front of a 15, 20-year-old experienced radiographer before I will some of the stuff that we're sending offshore for teleradiology in Australia. A lot of our stuff gets read in different countries, which is legally possible for non-Medicare work. But I'd rather have the old salty dog radiographer that's been looking at them for so many years reporting on my kid's chest x-ray if he ever has to have one. Big plug for Rains, and I also always acknowledge Jeff for the incredible effort he puts into the profession. But we're trying to start to build on training, giving people opportunities to work in advanced practice. So coming up in November, we're doing ECG interpretation, X-ray interpretation, nuclear medicine interpretation, CT course, and pharmacology. Because those are all examples I showed you before. I think I wouldn't say they're all minimum standard and capabilities, but if you're really into your profession and you only get out of it what you put in, you can be a real benefit to humanity. As you discussed, the Nuclear Medicine Advanced Associate, I was in the US for a sabbatical, and I got really engaged with some of the protagonists, and it has flaked out. They had an incredible structure. They had certain, Americans go fantastically into these sort of things, and they had a certification process, they had a training process. It's flaked out, I think, because of the paper I'll show you in a moment, but it's sort of simmering. I wouldn't say it's flaked out, but they can see opportunities there. They had a situation where you had to be experienced, on the floor for at least 2 years, and then you went into a graduate program. You had to train the trainer, teaching you on the run, TOR programs. And then you became rolled in, if you like, to the physician extender or the physician assistant program, which is another program for allied health practitioners that help, with cardiologists, endocrinologists and what have you. So you do some of the menial, you call it menial, but important tasks so that the smartest guy in the room can concentrate on the stuff where his grey matter needs to be. It took up to 2 to 5 years. Interestingly, though, this is a side issue. When they looked at 780 texts and asked them what have they performed in terms of drug use, interpretation, you can see the percentages are quite high, but when you look on the other side, how much received any formal training? Well, the percentages are quite low. So I don't know whether that's a good thing or a bad thing, but it's just something to note. And I think people would like to have the comfort of having a certification process to assist them. They also looked at the doctors at JNMT back in 2005, 1,500 of them, and their overwhelming support to extend technologists' work in the field. Thought it could free them up. They say all this in the surveys, but when it comes to the pointy end of signing, putting ink on the paper, it changes a little bit. But in any event, it did sort of show some level of intent. There was a paper came out last year, or the year before, which said don't be so quick to raise the white flag. I think that the problem is they're focused, I think, a lot of the technologists, and in talking to some of the protagonists over there, is that they're seeking greater remuneration. They want comp for this. Thanks. If you're not, I'm nearly finished. If you're not focused on and I love my Ting Dynasty sayings, and one of those killers for those emails that come through, but I love this one, obstacles don't break the path, it is the path. But if you're chasing the dollars, it's not going to work. You have to show that you're changing management and it's improving the problems with equity. So the next steps, just to finish off, the lessons from history is we keep forgetting the lessons from history. So I don't think we need to reinvent the wheel. A lot of the roadmap is already in place. Engage with the other associations that have been successful in this and propose the structure to all the stakeholders. Thank you.
Okay, thanks, Pete. You did well. You did well.
Done good. Thank you.